Good evening, dear members. The White Army is blessed and privileged to have with us Dr. S.R. Chandra, retired professor from MSRMC Bangalore. Welcome to you, madam. Dr. Priyanka, final year medicine postgraduate from MSRMC Medical College, is volunteered to present a neurological case. Welcome to you, Priyanka. With mentor's permission, we shall begin the session. All the best, Priyanka.
Thank you.
We'll start. Sorry.
Okay. So here is a patient by name XYZ, 23-year-old male. He resides at Jalahalli, Bangalore. He's a pharmacist by occupation, informant himself and the mother. He's right-handed person. So chief complaints. He complained of weakness of all 4 limbs since 1.5 months, complaints of restriction of the neck movements on the left side, and difficulty of shrugging of the left shoulder since 1.5 months, complaints of decreased sensation over the left shoulder and neck region since 1.5 months. Background history. Patient presented with alleged history of RTA skid and fall from 2-wheeler near Whitefield on 27th of August 2021 around 10:30 p.m. and sustained head injury and injury to the neck and right lower limb. With history of loss of consciousness, patient was intubated at Vaidehi Hospital in view of low GCS and was referred to Sanjay Gandhi Hospital. Patient was catheterized and he was on intubated and he was on prolonged ventilatory support, and patient was in coma for 25 days. And he was tracheostomized on 5th of August. And after that, he regained consciousness. He had complaints of weakness of all the 4 limbs. So he regained consciousness after 25 days, after which he noticed weakness of all 4 limbs. He was not able to move all the 4 limbs. So weakness was more in the left upper limb and bilateral lower limb. So when he noticed the weakness, he was not able to lift his left arm, left leg and right leg. He could slightly move his right hand. However, he was not able to grip objects or eat with his right hand. Gradually, over the course of time, there was gradual improvement in the right upper limb weakness, such that currently in the right upper limb, he is able to lift his right arm, have food with his right arm since the past 2 months. There is no improvement in the power in the left upper limb. Since past 1.5 months, he has noticed gradual improvement in the movements of bilateral lower limbs. He was able to slightly flex his knee and perform toe movements initially. Now he's slightly able to lift his right lower limb and left lower limb. He was able to roll over on the bed. There is no stiffness of the limbs, no involuntary movements. He complains of difficulty in turning the neck towards the left side and difficulty in shrugging his left shoulder. And there is no improvement of power on the left-sided neck movements. He also complains of decreased sensation over the left-sided shoulder region and left anterior part of the neck, clavicle region, and the backside of the neck, cape region. And no complaints of numbness or tingling sensation over any other body part. So only sensory loss, history-wise, there is only sensory loss on the left side of the shoulder region and neck region. All over the body, he doesn't have any other numbness or tingling or any other sensory loss. There is no history of bad leg sensation. He has complaints of difficulty in breathing initially and required oxygen. After being weaned off from ventilator, he was put on oxygen support for 15 to 20 days for the past 1 month. And then now he is off oxygen since last 5 days. No history of visual disturbances, headache, diplopia, ptosis. No, he is able to appreciate smell. He is able to look towards all sides. No history of sensory loss over the face. No facial deviation. No history of auditory disturbance. No history of restricted tongue movements. No history of difficulty in swallowing. No, he is able to speak well with the help of speech therapy. No history of bowel bladder sensation loss. No history of abnormal sweating. No history of shooting type of pain. No headache, vomiting, no history of seizures. Past medical history, he has no known comorbidities, no previous surgeries in the past, no history of contact with tuberculosis in the past. Personal history, bowel bladder habits are normal, sleep is sound, appetite is good, non-smoker, non-alcoholic, no history of deleterious habits, no history of weight loss or no history of decreased appetite. So, course after the background history and continuing with the course in the hospital, after he had RT and fall, after being intubated for 25 days and recovering from coma after 25 days and regaining consciousness.
Okay. Shall
He was
we?
shifted to MSRMC Hospital for further management, and in between, yes, ma'am.
So we will try to analyze the case as he came to the hospital. No. He was previously a well-preserved person according to you. No.
Yes,
and he had a road accident. At that time, he became unconscious.
Yes, ma'am.
So, you know that that part only we know initially. So at that time, what we would have thought is the site of his insult. That is what we have to know now. You see, he was unconscious. So as you know, what are the locations for consciousness? We have got two things. One is the depth, second is the content. So depth of consciousness is in the brainstem, in the ascending reticular activating system. So whether he had a brainstem insult, we don't know. You can have microbleeds, diffuse axonal injury, which can damage the brainstem. So many things are there. Or you have got a content of consciousness. So content of consciousness is altered, means patient will be delirious, he will be hallucinating, he will be aggressive, agitated, not identifying people. So those things were not there in this patient. So what was severely affected is the depth of consciousness. So you will measure it by Glasgow coma scale. I think they would have measured, and if the Glasgow coma scale is less than 7, it indicates a very poor prognosis. And if it is 3, it is as good as dead only. So based on that, they would have intubated the patient. So this patient became unconscious for what reason? One, was it the brainstem injury? Was the depth of consciousness affected because of brainstem injury? That is one question we have to ask. Because he did not have any seizures, he did not have any focal deficit. He had coma without focal deficit. You told that he was in coma for 25 days. So comatose patient, we classify them into coma with focal deficit and coma without focal deficit. Coma with focal deficit indicates a focal cause. For example, following trauma, if you have a intraparenchymal hemorrhage or intraventricular bleed or subdural or extradural, that will be producing coma with focal deficit, and the coma being due to herniation. Whereas if you have coma without focal deficit, we think of a midline structure getting involved or metabolic, electrolyte or systemic cause causing the coma. So coma without focal deficit is generally due to a midline pathology or due to a systemic metabolic insult. Whereas coma with focal deficit is due to a focal cause with herniation. So in this patient, we will call it as coma without focal deficit and a coma without any evidence to suggest the content of consciousness was altered at that time, which could be either due to his deep coma and he was probably on anticonvulsants prophylactically, whether that is true, or due to the brainstem involvement that he was comatose and he did not have any hemispheric features. Second thing, we classify, so different methods to explain how a person with road accident can be comatose. What I told, one is brainstem insult. Second, he had some other structure involvement which resulted in hypoxia, cardiac arrhythmia, electrolyte imbalance, systemic cause producing a coma without focal deficit. Or third, we classify head injuries into dynamic injuries and penetrating injuries. Penetrating injuries are like a sword being passed through a part of the brain. So that will produce again features based on the structures that are pierced by the thing which is piercing the brain. So that generally does not produce unconsciousness, but it produces focal deficit. So it is penetrating injury. Whereas dynamic injury, that will produce shearing stress. So like for example, your bus is running and you are getting jumping out of that bus. It's a dynamic injury because the body of the speed of your body and the speed of your limbs are in different range. Your leg is 0 and your body is the speed of the bus. So there is a shearing stress resulting in multiple microbleeds. and that produce more coma but no focal deficit. So in a head injury, coma without focal deficit can be due to non-penetrating dynamic head injury resulting in axonal injury, or due to direct insult to the brainstem, or it could be due to other system involvement like a collapsed lung or internal hemorrhage or cardiac arrhythmias resulting in a diffuse suppression of brain function either due to hypoxia, hypovolemia, hypotension. So these are the things we will consider and when the patient is comatose. So he underwent coma management, and after coma management, when he recovered, you mentioned that he needed speech therapy to speak.
Yes, ma'am.
So what was his speech problem? So that might find whether he had a focal problem. I want to know. So you understood why a person with head injury can be comatose. It can be due to brainstem insult. It can be due to dynamic head injury resulting in diffuse axonal damage, or due to a systemic cause like an internal hemorrhage, cardiac arrhythmia, respiratory distress, producing a common insult diffusely damaging the brain. So these are the three possibilities, and that we do not know at that time except that he was comatose. Now when he is recovering, you said that he needed speech therapy. That means there was a problem with his speech. So what was his speech problem that needed the therapy? So you have to see whether it is a speech or a language. So if it is a language problem, you will again know that it's a dominant perisylvian region, some insult happened. So what was his problem with the speech? Because of which speech therapy was asked for. Are you aware of that? Did they tell you the history?
Ma'am, only because of the tracheostomy, he was able to produce voice, he was able to speak, but the quality of the voice was little slow.
Okay. So that means it is definitely not a language. So that you should be telling that he could comprehend, he could understand, he could express. Only thing, the quality of the speech was hoarse, probably secondary to the tracheostomy, and you had a stridor. For that, he underwent. You will not call it as a. Actually, they don't do any speech therapy for that. Yes, you see, you do speech therapy if the person has got a spastic speech, cerebral nerve speech, flaccid speech, then the lower motor and upper motor neuron will be put into activity. Or you can have a language problem, then there will be language therapy. Here, I had a hoarse voice means there is really no therapy that is actually indicated. And he might have had a stridor or hoarseness due to tracheal edema. That will come down when the tracheal edema subsides. So if that was the thing, I don't know why speech therapy was given. So okay, that part anyway, language was not involved, so that is not giving us a clue regarding whether he had a focal deficit. So any of these three things or many things together could have contributed to his coma, but he recovered from the coma with good cognitive function. Is it so?
Yes, ma'am.
So his pharmacy information is retained.
Yes, ma'am. He was able to answer everything, all the questions.
In that case, what is your inference? So a person was comatose for 25 days and recovering with intact cognition. What are the situations that can happen? Can it happen with the brainstem bleed? Can it happen with the diffuse axonal injury? It cannot happen. So if the person had a diffuse axonal injury, there will be multiple microbleeds in the brain and they cannot get back all the cognitive functions after 25 days of coma. Second, after 25 days of coma, a person with brainstem damage also cannot get normally. He will have so many other brainstem features. So the possibility for the coma most likely is either it was a drug-induced coma, patient might have been in pain or something, and they would have given sedative drugs, and after that you don't know where is the pathology, and so patient can be, usually it is a drug-induced coma or metabolic coma, where the patient gets back to the cognitive functions normally. Even hypoxia does not come back, even hypotension due to internal hemorrhage, they do not come back to absolute normal cognitive functions. So usually it is the drug, or it can be due to some other metabolic cause like hyponatremia or hypoglycemia or some electrolyte imbalance that was there, which got corrected with the supportive management. if you think that a 25 days coma and cognitive functions are intact, it cannot be due to anything structural. Axonal injury, as I told, it will produce diffuse microbleeds. So there will be cognitive deficits. Brainstem injury, significant lower cranial palsy and other brainstem features will be there. Or internal hemorrhage, severe hypotension. So they will have problems. So nothing is there and cognitively very good. Means it is very less likely that he had any serious brain injury. Very unlikely. I am sure it is your inference also. A serious brain injury causing coma, patient will not get back the cognitive functions after 25 days of coma. So you put the patient on ventilator after so many, then morphine, pethidine, so many drugs and neuroparalytic agents will be given. So that might be suppressing the patient's consciousness rather than just structural damage to the brain. Because 25 days coma is not a small thing. So after that, cognitive functions normal means it is very unlikely anything structural happened to the brain. So that part we will keep it like that. So the next symptom is he had weakness of, he had difficulty in turning the neck to the left side. No?
Yes, ma'am.
And he developed weakness of all three limbs other than the right upper limbs. No?
All four limbs weakness was there, ma'am, but the right upper limb he was able to move.
So there was an asymmetrical weakness involving 4 limbs where the right upper limb was relatively better.
Yes, ma'am.
Okay. So which part, what all things can happen in a situation like this where these persons can develop all 4 limbs weakness, that we will see. So what was the weakness? I am sure that he's so sick you will not be able to get proper history from him. Was he stiff or was he having any seizures or did he have distal weakness or proximal weakness? I agree with you that it is difficult to get all those history in such a sick patient. So we will think about what are all the possibilities. So if you club the coma and quadriplegia, can you think of anything? For theory part only I am telling. It may not be this patient's case, but coma followed by quadriplegia. Can you think of any condition? Prolonged coma, which was there in these patients. No. And cerebral after that, which one, ma?
Cerebral paraplegia.
Yes, what is cerebral paraplegia? Very good. But coma followed by paraplegia, quadriplegia could be cerebral paraplegia. Cerebral paraplegia happens in which part of the brain getting involved?
Above the level of medulla.
Cerebral paraplegia happens in a parasagittal pathology. You see, lower limb area is there. So parasagittal pathology, usually if it is vascular, anterior cerebral artery distribution. Anterior cerebral artery supplies the leg area. Both leg areas are there in the interhemispheric fissure. So if that leg area is getting affected due to anterior cerebral artery involvement, you get cerebral paraplegia. So what are the typical features by which you differentiate a cerebral paraplegia from a spinal paraplegia? One thing, as you said, patient may be in coma before. Whereas spinal paraplegia, they do not become comatose. If they are linked, we do not know whether to associate or dissociate. If you have to associate, what are all the things we have to think? If you have to dissociate, what are all the things we have to think? That's what we are considering. So if it is cerebral paraplegia, it is usually a parasagittal pathology, which could be vascular or non-vascular. Because in the medial interhemispheric fissure, the leg area is there. So one thing, history of higher cognitive dysfunction like coma, seizure, all those things are there. You think of cerebral paraplegia, spinal paraplegia, those things do not happen. Second, cerebral paraplegia patients can have seizures in the lower limbs. Whereas an equivalent of that in the spinal cord is a clonus. So they may tell jerkiness. So jerkiness, if you are confused whether my patient is saying cerebral jerkiness, you may put it as a seizure. So it's a rhythmic marching movement is the seizure. Whereas when you press your limb on the floor or any structure, repetitive jerking is clonus. So cerebral paraplegia can have seizures in the lower limb, whereas spinal paraplegia has an equivalent in the form of clonus. Third point, cerebral paraplegia is usually associated with the frontal bladder. use and use catheterize. But I agree that comatose patient, you will not be able to characterize the bladder. But if it is a Fox antisalvatory infarct or a Fox meningioma, which produces cerebral paraplegia, the bladder will be a frontal uninhibited bladder. So patient will pass urine in forbidden places and he will say that, what is wrong? If I pass urine inside the bedroom, it is my house only, why are you worried? That is the frontal uninhibited bladder. Otherwise, the patient will have normal bladder sensation. If he wants, he can restrain the bladder. He can go to the toilet and pass. But he will have an unconcerned for the social cognitive inhibitions. So he will pass urine anywhere. Whereas a spinal cord bladder is usually an automatic bladder. So automatic bladder, the pre-voiding phase. Patient usually mildly appreciate bladder sensations or does not appreciate bladder sensation, depending on whether the spinal cord involvement is partial or complete. So that is pre-voiding phase. Whereas cerebral paraplegia, patient appreciates sensation. Spinal cord partially or completely lost bladder sensation. Then because the sacral center has a capacity to store up to 300 to 400 ml, the urine will be accumulated up to 300 to 400 ml. And once that urine accumulates, automatically the sacral center initiates micturition. So patient will not have any control over initiation of micturition. Whereas the frontal bladder, patient has control, but he will simply void and say, it is my house, I will void, like that. Whereas spinal bladder has no capacity to initiate or no capacity to terminate. Then the bladder empties about 300 ml automatically. He cannot stop in the midstream, and at the end automatically it stops with the residual urine. Whereas frontal bladder, pre-voiding phase fullness is appreciated. Once appreciated, he does not take the strain to go to the toilet, instead passes and justifies his action. If he wants, he can stop in the midstream and he can empty completely without residual urine. That is the cerebral paraplegia bladder, whereas spinal bladder is automatic bladder. The next symptom in the cerebral paraplegia, because as you know, the motor cortex, the hip downwards is in the interhemispheric fissure, whereas in the sensory cortex, it is below the angle. So patient will have a cortical sensory loss below the angle. So when you examine only, you will know that it is cortical sensation and not other sensation. So you have a paraplegia with the cortical sensory loss below the angle due to adjoining cortical sensory areas getting involved, whereby homunculus, the sensory part of the lower limb is not from the hip. In the interhemispheric fissure, it is from the angle. Whereas in the spinal cord, there will be a sensory level based on the site at which the spinal cord is transected. Then if you see the reflexes, both situations, the reflexes will be exaggerated, plantar will be upgoing. So that is cerebral paraplegia and the spinal paraplegia. And the most important point in a severe paraplegia like this patient, a cerebral paraplegia never goes to paraplegia in flexion. Even if the paraplegia is very severe, unlike a spinal paraplegia, when it is severe transection of the cord, patient will get flexor spasms and it will go to paraplegia in flexion. Whereas cerebral paraplegia never goes to paraplegia in flexion. It never occurs. It is always paraplegia in extension. And I think I would have told the reason in some other classes. I can tell it again if you have not heard it before. You see, when you know that you have got a spinal extrapyramidal system, that is vestibulospinal and reticulospinal tracts in the spinal cord. They are the most resistant tracts to insult. They are concerned with the extensor tone. So spinal extrapyramidal system maintains extensor posture when there is an incomplete cord lesion. When the spinal cord lesion is complete, that damages even the vestibulospinal and the reticulospinal tract. The extensor tone cannot be maintained. Because of that, the short latency flexor reflex afferents, which are operational when you are born. When you are born in the spinal stage, the child will be in universal flexion. So the short latency flexor reflex afferents, which get inhibited around 7th or 8th month of postnatal life, becomes disinhibited, resulting in paraplegia and flexion. Whereas in cerebral paraplegia, short latency flexor reflex afferents are not at all involved. They are not at all disinhibited. Because of that reason, cerebral paraplegia never produces paraplegia and flexion. So that is the thing to differentiate. So one, you told about cerebral paraplegia. Second, in this case, we thought that as the patient has developed complete recovery of cognitive functions according to your gross assessment, second thing we will consider is something called man in the barrel syndrome. Watershed infarct. Supposing he has had a polytrauma. Usually road accident is a polytrauma. They may have a visceral hemorrhage inside the abdomen or thigh muscle, femoral artery. Somewhere they can bleed and they develop hypotension. When they develop hypotension, there is something called man in the barrel syndrome. Man in the barrel syndrome is a quadriplegia where the upper limb is weaker than the lower limb. Why that happened? If we can recall the vascular supply of the brain, the interhemispheric fissure is supplied by the anterior cerebral artery. In the Sylvian fissure, you have got the middle cerebral artery. So perisylvian area is getting good perfusion from middle cerebral artery. Interhemispheric region and a small strip over the superior lateral surface close to the interhemispheric fissure is getting blood from the anterior cerebral artery. In between zone is the perfusion area, watershed area. In between the perisylvian area and the spillover from the interhemispheric fissure, there is an area. That area is otherwise called watershed area. This area gets a perfusion from anterior cerebral artery as well as middle cerebral artery. When there is a hypotension, this watershed area will suffer maximum. It is like you have a water tank. From there, water is pumped. The houses which are far away will have the least pressure. Like that, the area in between the perisylvian and borderline parasagittal area is the watershed area for ACA and PCA. That area has the hand area. So by homunculus, you know that head and neck is towards the in the sylvian fissure, upper limb, neck, trunk is in the superior lateral surface, lower limb is in the interhemispheric fissure. So that watershed area is upper limb area. So both upper limbs get knocked out and lower limbs becomes less involved. That results in a watershed infarct on both sides because the hypotension is a common insult. So that is called man in the barrel syndrome. So if you want to link the coma and consider a serious brain insult occur, as you rightly said, one, it could be a anterior cerebral artery dissection, something like that, resulting in a cerebral paraplegia due to an anterior cerebral artery occlusion, or it can be a watershed infarct where the pattern you expect is upper limb will be more involved than the lower limb. And they can have cognitive dysfunctions, disorientation, delirium, all those things. Next, whether the patient had a spinal cord injury. So spinal cord injury can happen in what all ways in an accident. One is diffuse, one is whiplash injury. You might have heard of whiplash injury. So what is whiplash injury? Again due to dynamic injury. Whiplash injury, what happens? You have got the transverse ligament of the odontoid and the odontoid behind. So when there is a dynamic injury taking place, there is a sudden stretching of the transverse ligament of the odontoid. So the odontoid comes, strikes the spinal cord and goes back. So there will be central cord changes resulting in upper limb again will be whiplash injury again because the central cord gets involved. As you know, in the lamination, in the pyramidal tract, upper limb fibers are medial, lower limb fibers are lateral. So it is the upper limb again which gets weaker due to central cord edema. That happens in whiplash injury. So that is one cause. So first cause, as you said, it could be cerebral paraplegia, Second, watershed infarct due to hypotension, hypovolemia. Third, whether it is a whiplash injury, then you get an upper limb more weaker than the lower limb. Next types of cord involvement, it can be fracture dislocation. So fracture dislocation can result in cord compression. It will be extradural, extramedullary compression. So next you can get a partial transection of the cord, traumatic hemisectioning, transectioning, vascular infarct, all these can happen. So what happened in this patient? Clearly it is not looking like a cerebral paraplegia apparently, because now cognition is good. It is not looking like a man in the barrel syndrome due to watershed infarct, because again cognition is normal. And it is not looking like a whiplash injury, because you said that all four limbs are equally involved except mild relative sparing of the right upper limb. Instead, you told that there is an area of sensory impairment
in the left
over the left shoulder region. So that indicates shoulder region is supplied by what area?
C2.
C2 is supplying the
nape of the and the earlobe.
Suboccipital region is supplied by C2. You said it is shoulder, no? Is it suboccipital region or shoulder?
Shoulder, both.
Shoulder is supplied by C5. So this area is C5, this is C6, this is C7, this is C8, and this is D1. So C5, C6, C7, C8, D1. Whereas this area is C2, suboccipital area is C2, and the neck is C3, C4. So if it is the shoulder, it is C5, and apparently it looks like a root was involved. So root and quadriplegia is otherwise called as myeloradiculopathy. So there is a radiculopathy and a myelopathy. So in our patient, it is not cerebral paraplegia, it is not man in the barrel, it is not central cord syndrome due to whiplash apparently from the pattern. Instead, it looks like a radiculopathy and a myelopathy, and it is radiculopathy on the left side. And you said that there is mechanical restriction of movement to the left side. Was it due to pain?
No, ma'am, he didn't have any pain.
So why is he not able to move? It must be due to pain only.
No, ma'am,
or is he stiff? Or is he stiff there?
No, there is hypotonia of the left upper limb and
No,
power.
neck.
Neck.
He is not able to move the neck to the left side.
Yes. There is weakness of the left-sided neck muscles. He was operated, and after the operation, he's not having pain. Currently, during the time of examination, he did not have any pain, ma'am. And since the time of recovery from the coma, he's having the weakness towards the left.
You say that it is due to weakness only when you examine the power, no? So yes, generally we tell unable to move the neck to one side means usually it is stiffness. Weakness, you examine the power, then only you find out. Anyway, whatever it is, you definitely has got a C5 radiculopathy with a myelopathy. So it is a myeloradiculopathy, and the highest level according to your localization is C5 root and myelopathy below that. He has no bulbar symptoms, he has no speech, all those things you said. So it looks like a myeloradiculopathy. At this point, I will want to tell how to categorize a spinal cord syndrome. Apart from the whiplash, which I said, which we have told in the previous classes also, you categorize that into pan cord syndrome, anterior cord syndrome, posterior cord syndrome, hemicord syndrome, central cord syndrome, and tractopathies. This is how you categorize spinal cord. So pan cord means all the structures. That is corticospinal, spinothalamic, posterior column, everything is getting involved. It is called a pan cord. Anterior cord means other than the posterior column, other structures are getting involved. That usually happens in a vascular syndrome, anterior spinal artery occlusion. Then you get anterior cord syndrome. Generally, anterior cord syndrome happens in anterior spinal artery occlusion, and there are other conditions also where it can happen. Then you have got a posterior cord syndrome. Generally, even though theoretically we can say that it happens in posterior spinal artery occlusion, which is very, very rare. So posterior cord syndrome is typically seen in conditions like tabes dorsalis or pseudo tabes of diabetes. Such conditions you get a posterior cord syndrome. Even though posterior spinal artery occlusion is a theoretical thing, it is very, very rare. Second is a hemicord syndrome, where you have a partial transection of the cord either due to trauma or due to tumors. So that is called Brown-Sequard syndrome. Brown-Sequard syndrome, you will get ipsilateral pyramidal and ipsilateral posterior column, contralateral spinothalamic. So that usually, as it was first described in injuries only, gunshot injuries, war injuries, where Brown-Sequard syndrome was described, and later people found even spinal gliomas and arteria corona occlusion. There also you can get a Brown-Sequard syndrome. So anterior cord, pan cord, posterior cord, hemicord, central cord is whiplash injury. Then what you call as tractopathy, tracts get involved. For example, if you think posterior column and corticospinal tract, it is not respecting a vascular territory, but these two tracts are selectively involved. That is seen in subacute combined degeneration. Primary lateral sclerosis, only the corticospinal tract gets involved. That is the degenerative process picking up the corticospinal tract. You have got hereditary spastic paraplegias, hereditary spastic ataxias. They select selective tracts. They are all called tractopathies, where there is a degeneration specific picking up of tracts. So these are the various causes of cervical cord involvement, how to categorize a cord involvement. If you want to put it, you said that there is upper limb sensories involved, otherwise there is no sensory involvement. So that it is an incomplete myeloradiculopathy, and apparently the structures involved in our patient are C5 root and corticospinal tract below that. Does he have a bladder involvement? Is he still on catheter now?
No, ma'am. He was off catheter and he's having bowel bladder sensation. There is no bladder loss of sensation.
Okay. So now it is, what are the structures involved in our patient is C5 root on the left side and corticospinal tract on both sides, which are producing the symptoms. So now we want to know how are you. So we have described all the patterns of spinal cord involvement. Next question, how to differentiate a compressive cord lesion from a non-compressive cord lesion. So compressive cord lesions usually have a definite upper level, whereas non-compressive cord lesions like nutritional myelopathies, toxic myelopathies, they do not have a definite upper level. Second, compressive cord lesions usually are short duration, whereas non-compressive lesions such as P+, very long duration. Nutritional myelopathies, toxic myelopathies, very long duration. So non-compressive myelopathies are of long duration. Third point, non-compressive myelopathies will have unconnected signs. Like for example, a person with myelopathy can have peripheral neuropathy. A person with myelopathy can have optic atrophy. A person with myelopathy can have deafness. Whereas unconnected symptoms are uncommon in compressive myelopathy. They all respect a plane. Third point, bladder involvement is very late in non-compressive myelopathies, whereas early bladder involvement is usually seen in compressive myelopathies. Then of course, you will be able to demonstrate paraspinal muscle spasm or compressive pathology. So in this patient, you have a definite upper level. It is asymmetrical. No? It is short duration. And it happened in the context of a trauma. And to get a root sign, you have to produce a foraminal compression. So this probably is a compressive paraplegia for the following reasons. One, it is very short duration. And trauma-induced whiplash injury produces upper limb more than lower limb, whereas this person has got all four limbs and he is having a feature suggestive of myeloradiculopathy. So it is probably compressive. Short duration, definite upper level, asymmetry, pointing to a probably compressive pathology. distant signs were not there other than the coma, which we are not sure is due to significant brain insult. Then you have to see how to differentiate compression at the level of intramedullary compression, intradural compression, and extradural compression. As you know, extradural compression is usually vertebral or disc pathology, whereas intradural compression is neurofibromas, meningiomas. Intramedullary compression is syringomyelia or intramedullary tumors. So these are the, keeping this in mind, you will have a, because extramedullary is vertebral pathology. So you can have a gibbous. You can have a local tenderness. You can have paraspinal muscle spasm. Usually extramedullary is symmetrical, because usually supposing you have got a osteomyelitis of the vertebra, usually it involves the disc space and then only goes to the adjoining area. So extramedullary, extradural, one is the presence of gibbous, second is local tenderness, usually symmetrical, but it is not a rule. Paraspinal muscle spasm is usually present, and bladder comes late. Depending on the degree of compression, you can have complete or incomplete cord lesion. But in incomplete cord lesions, the structures which are going to be involved are the pressure sensitive structures. What are all the pressure sensitive structures? One is the posterior column, second is the corticospinal tract. Whereas compression sensitivity is for posterior column and corticospinal tract. Whereas vascular insult, that picks up the spinothalamic tract and the autonomic fibers. So vascular insults generally prefer the pain and temperature fibers and the autonomic fibers, whereas compression picks up the posterior column and the pyramidal tract, and demyelinating disease pick up the posterior column and the pyramidal tract, and toxins spare the autonomic. So that is a special vulnerability. So compressions prefer the posterior column and the corticospinal tract. So the third feature is relatively early bladder compared to the non-compressive myelopathy. And bladder involvement, we say that intramedullary is early, but it is not always true. Intramedullary is early, provided the intramedullary lesion is intrinsic demyelination, like acute transverse myelitis, then bladder is early. But supposing it is a condition like syringomyelia, bladder is late only, whereas extradural, extramedullary compression is little more earlier bladder. So that is feature suggestive of extramedullary, extradural. So gibbous, tenderness, mechanical restriction of the movement of that part, paraspinal muscle spasm, presence of root signs, and pressure sensitive corticospinal and posterior column involvement, and relatively early bladder compared to non-compressive and intramedullary, that is extradural, extramedullary. Second, we will come to intradural. Intradural, as I said, it is neurofibromas, meningiomas, which start from the roots on one side. So these people do not have any gibbous, they do not have paraspinal spasm, they do not have mechanical restriction of neck movements, they have root pains, but root signs are less, because the lesions themselves start in the root only. Because of that, they may express early root pains, but when you examine, the root signs are relatively less. Whereas in the extradural, root pains and root signs are more, because it is in the foramen where they get compressed. Whereas intradural space is there. The tumor starts from the nerve root, so root pains will be there. But root signs take time, because the roots are not jammed or fixed in the foramen. They are in the intradural space. And the myelopathy is usually asymmetrical, because it starts on one side and over a period of time only, it comes and involves the opposite side. Then you will have late bladder only. Then intramedullary, and you will have sensations which are ascending, both in the intradural and the extradural. Sensations ascend from below upwards. Then you take the intramedullary, you do not get any gibbous, you do not get any paraspinal spasm, you do not get any root pains, you get a tract pain. Tract pain involving the spinothalamic tract, which is suspended and dissociated at the level of involvement. it will not have any precipitating or relieving factor like the root involvement. And bladder is yearly if it is a central canal dilatation like hydromyelia, or it is an intramedullary tumor, or intramedullary demyelination, bladder can be early. Otherwise, conditions like syringomyelia, bladder is late only. So descending sensory loss, tract pain, dissociated, suspended anesthesia, with the late bladder if it is condition like syrinx, and early bladder if it is conditions like demyelination, and no gibbous or paraspinal spasm. So now we think that there is a definite upper level, short duration, setting of trauma, root and cord, and apparently corticospinal tract is involved. There is a root involvement. So it's a myeloradiculopathy, which is now with the signs and symptoms on the pressure sensitive tract is getting involved. Most probably it is, and it is a symmetrical quadriparesis with mild sparing of the right upper limb. So we'll have to think of probably an extramedullary extradural compression at the level of C5. Probably it is a fracture or a disc disease at the level due to the trauma. Whether you had a disc also, we don't know. Next, I will tell you about some patterns which you will be asked in your exam. What is Ellsberg pattern? What is Z pattern? What is pseudo-syringomyelic pattern? So those things also you should know. Apart from the patterns I described, what is Ellsberg? So our patient is having a myeloradiculopathy, very typical straightforward pattern. Myelopathy is there, radiculopathy is there. Ellsberg means you are having, here it is LMN involvement of the upper limb, sensory involvement of the upper limb. That is what your patient is having. Whereas UMN involvement of one upper limb, followed by UMN involvement of the same side lower limb, then UMN involvement of the opposite side lower limb, then completion of the pathology producing opposite upper limb. So you want to ask, is it an Ellsberg? My patient is having left upper limb, left lower limb, right lower limb very weak, right upper limb is towards completion. So is it an Ellsberg? That question also you have to ask, because he was comatose, we do not know how it evolved. So Ellsberg means, remember, it is not LMN. Whereas root pain is LMN, root sign may be there. So Ellsberg is UMN involvement of one upper limb, then ipsilateral lower limb, then contralateral lower limb and contralateral upper limb by completion of pathology. So what you should remember about Ellsberg is, it is due to, if whatever is the compression, if it starts with infarction of the medial pyramidal fibers, because of the sulcocommissural artery ischemia. You have got antispinal artery, you have got postspinal artery, you have got arteriocoronal and sulcocommissural artery. Sulcocommissural arteries are supplying medial pyramidal fibers, crossing spinothalamic and ventral horn. So if the sulcocommissural artery supplying the medial pyramidal fibers are involved by whatever compression, that starts the Ellsberg phenomenon. So what you should remember, if you operate also that compression, if the patient has presented with Ellsberg phenomena, the infarcted upper limb is going to have the least recovery. So it is a prognostic relevance. Ellsberg is due to ischemic infarction of the medial pyramidal fiber due to sulcocommissural artery. That is Ellsberg phenomenon. Next was it, what is an Z pattern? Z pattern is one upper limb LMN, then opposite upper limb LMN, then opposite lower limb UMN, then ipsilateral lower limb UMN. That is Z pattern. That happens in foramen magnum lesions, which circumvent the cord, like lipomas, neurofibromas, plexiform lesions, which go around the cord, pick up the root, and then pick up the spinal cord. That is Z pattern. Then, as I told, central cord pattern is whiplash injury, and you have got pseudo-syringomyelic presentation when again the sulcocommissural artery is infarcted, which supplies the crossing spinothalamic tract. That is a pseudo-syringomyelic. Then you have got a cervical paraplegia, because you have got the upper lower limb fibers outer the spinal cord. So if there is a canal stenosis, the outwardly placed lower limb fibers get compressed first, and it will start like a lower limb weakness. That is called cervical paraplegia. So these are the various patterns. Among all these patterns, our patient is having a short duration, fairly symmetrical myelopathy involving the pressure sensitive corticospinal tract. Whether the posterior column is involved, we have to examine and find out. And there is a radiculopathy. So it's a short duration myeloradiculopathy with a definite upper level. Bladder is not involved, other sensations are not involved. So it's a partial cord myeloradiculopathy. So now we'll go to examination. On examination, what did you find? Tell me.
On general physical examination, well-built, well-nourished male, conscious.
Any doubt also you can ask. I just covered all the patterns. You can go and read now. It will become clear.
Ma'am, this patient most likely would have been in Ellsberg phenomenon, ma'am. With the
Ellsberg means after exam, we don't know. You are not examining now. Now you have a definite element. You have an element in the form of a root. Whereas Ellsberg is UMN involvement of the upper limb on one side. You are not examined. You are not told me the findings. So no, don't need to conclude before you examine. Ellsberg means it is UMN involvement of, we don't know, no, he was in coma. Was he there to tell you that I got UMN involvement of left upper limb, then the left lower limb, then the right lower limb? Then no. It is not there, so we do not know. We have no idea. So that history is not there. He was comatose. And now what we have is a root. So it's a myeloradiculopathy, not an Ellsberg. Okay.
General physical examination, well-built, well-nourished male, conscious, cooperative, oriented to time, place, and person. Vitals, blood pressure 120/80 mm of mercury in right arm, supine position. Pulse rate is 94 beats per minute, regular rhythm, no radioradial, radiofemoral delay. Peripheral pulses were well felt. Respiratory rate was 18 cycles per minute, and saturation he was maintaining on room air. Head-to-toe examination, palar was present, no icterus cyanosis clubbing, no lymphadenopathy. Tracheostomy tube was in situ. He was on air with left upper limb.
It has not been removed so far.
No, he was just like decannulation was going. After 2-3 days, he was planned to remove. Left upper limb was flexed and medially rotated. Right lower limb was abducted
and medially rotated. Okay.
Right lower limb was abducted and laterally rotated. There was no signs of Horner syndrome. CNS examination, higher mental functions were normal, ma'am. Appearance, behavior, consciousness, memory was intact.
In that case, what did you decide about the 25 days coma? Can any patient due to severe brain injury get normal higher mental function after 25 days coma? Definitely not possible. No?
Yes.
Okay, so like what
due to metabolic insult.
Yes, most likely. Okay.
Cranial nerve examination. All cranial nerve examinations were normal, ma'am, except for the spinal accessory nerve. There was weakness of the left side. Sternocleidomastoid muscle and trapezius muscle was weak on the left side. Motor system examination.
Both were weak. Left sternocleidomastoid and trapezius.
Trapezius, yes, both were weak. Motor system examination, muscle bulk, right arm 26 centimeter, left side that was 25 centimeter, forearm 22 centimeter, both the sides.
What about his tongue and all? Tongue was normal.
Tongue was normal.
Tongue,
no
palate, all normal.
Tongue, palate was normal.
Okay.
Tone, right upper limb tone was normal. Left side hypotonia was there in the left upper limb, lower limb, and right lower limb. Show examination of the power right shoulder, right side 4/5.
Left upper limb was hypotonia.
Yes, ma'am, hypotonia.
It's difficult to believe because yes, you told that his left upper limb was in flexion.
Yes, ma'am.
So hypotonic limb will never be in a flexion posture. That means if you have to have a limb in a flexion posture, that means that the hypertonia in the biceps. If a hypotonic limb, I am sure you know, it will fly like that. It will not adopt any posture. So there is some mismatch. Either that posture was simply somebody has put his hand in that posture and you saw it, or He has no hypotonia. Either of the two only can happen, because you know that the flexion posture means there is a flexor hypertonia. Otherwise, you cannot have a flexion posture. It cannot happen. No.
Most like the tone was hypotonia was there, ma'am. Maybe he would have kept his hand in the flexion point.
Okay. So when you observed him, somebody has mechanically put his hand like that. So that posture has no relevance. Okay. Then all four limbs are hypotonia. Then
right upper limb power was 4/5. Flexion, extension, adduction, abduction. Left upper limb power was shoulder, flexion, extension 1/5, 1/5. External rotation, internal rotation, all the power was 1/5. Elbow flexion, extension 1/5. Wrist flexion was 1/5. Extension was 2/5. Ulnar deviation, radiant deviation was 1/5. Right side upper limb shoulder flexion was 4/5, but elbow and wrist flexion was 5/5.
So apparently right side is normal only. Okay.
Left side lower limb, right lower limb, he had fracture, ma'am, fracture of the femur shaft of the femur fracture. So we had not examined the right thigh muscles. Then knee joint flexion extension was 3/5. Then ankle dorsiflexion, plantar flexion was 3/5 and 4/5. And right side lower limb, hip joint flexion extension, adduction, abduction, all were 4/5. Knee joint flexion extension was 4/5. Ankle joint was also 4/5.
Right side only, you said that femur was fractured, no? Right or left?
Right side.
Okay.
Left side also he had regained power. Left lower limb was almost 4/5, ma'am. Then ankle joint, subtalar joint, inversion, eversion, both the sides 4/5. Right lower limbs. There was no fasciculations noted. Deep tendon reflexes, all reflexes were exaggerated. Bicep supinator, ankle jerk. Jaw jerk was absent. Superficial sensations, corneal sensation, conjunctival abdominal reflex was present. Plantar was bilateral flexors. And cortical sensory examination, it was 2-point discrimination was normal. Tactile localization was normal. Graphesthesia, stereognosis was normal. Sensory system examination, there was loss of pinprick, pain, touch, temperature, sensation over the C2, C3, C4, C5 dermatomal distribution. Touch, pressure, pain, temperature over rest of the body was, all the other dermatomes were normal. Joint position, vibration sense was normal all over the body. Even in the left upper limb, joint position, vibration sense was normal, ma'am. Romberg test was not done.
Okay.
Coordination, finger nose test, dysdiadokinesia, it was impaired on the right side. Left side
so
not.
You said now in the C2 to C5 area, pain and temperature was reduced. What about the touch?
Ma'am?
C2 to C5 area, you said that the pinprick and the temperature sensations were reduced. What about touch in that area?
Touch, pinprick, pain, touch, crude touch, fine touch, both were also reduced, ma'am.
Okay. Then, okay.
Then there was no signs of meningeal irritation. Spinal tenderness was present over the C2 vertebra. There was no local swelling or deformities, and grade 2 bedsore was present over the sacral region. Other system examination, respiratory system, trachea was central, tracheostomy tube was in situ, patient was on room air, bilateral normovesicular breath sounds heard. Then cardiovascular examination, system examination was normal, perabdominal examination was normal, and there was no mass palpable. And he was not catheterized.
Okay. So his bladder is normal. So yes. After examination, what are the structures which are involved now? Quadriparesis. You are getting some pattern. The pattern is upper limb. Okay, right lower limb, we'll forget about it. There is a fracture. It's an asymmetrical cord lesion. First, no.
Asymmetrical cord.
Upper asymmetry is both in the vertical and transverse plane. You can see that the asymmetry is involving upper limbs are more involved than the lower limb. Upper limb is sensory motor, lower limb is only motor, and the right side is relatively better preserved. Lower limb, of course, you could not examine properly. So left upper limb was hypotonic. What about the lower limb? Were they hypotonic?
Yes, ma'am. Lower limb, left upper limb and both lower limb was hypotonic.
Lower limb also hypotonic.
Yes, ma'am.
So how do you explain the hypotonia? What all ways you can explain the hypotonia in the left upper limb? Let us see that. Because there is a clear evidence for extensive radiculopathy from C2 to C5. All modalities of sensations were impaired from C2 to C5. So it is because of the knocking down of the element in that level that there is hypotonia there. So you can explain hypotonia by shock sometimes. So will you call it as a shock in this case?
Yes, ma'am. Patient can be in the recovery stage of spinal shock to have a hypotonia.
In this patient, now I am not telling theory. In this patient, will you consider shock?
Yes, ma'am.
You definitely not, because shock means there is loss of all functions below a particular level. So it will not be asymmetrical. It will be symmetrical. There will be symmetrical loss of tone, symmetrical loss of reflexes, and there will be bladder involvement. And usually does not go on for 1 month, 2 months like that. And the shock duration is determined by some factors. One is the species. Animals have more function for the spinal cord. So animals have a shorter shock. Human beings have a longer shock because we have very little function for the spinal cord generally, other than a transmitting function. So human beings have longer period of shock, animals have lesser period of shock. Second, human beings lesion which is closer to the, as the lesion moves closer to the brain, the shock will be more. As it shock will be less. As it moves away from the brain, the shock will be more, because the function, automatic function becomes less and less. Then if there are secondary complications like infection, the shock will be more. So this is not due to shock, because there is a definite asymmetrical radicular feature, and usually it doesn't last 1 month and all. It never lasts. So when it is an asymmetrical neurological deficit, and you do not call it as a shock. So this is not shock. Shock is symmetrical, hypotonic, loss of function for a disconnected spinal cord during the period when cerebral information is not being transferred to the spinal cord, and spinal cord tries to discover its own capacity. And it takes, usually in human beings, it takes about 4 to 5 days. And the first thing to recover is the sensory, second is to recover is the motor, third to recover is the sphincter, fourth last to recover is the reflexes. So this is asymmetrical, it is long duration, it is radicular, and it is not due to shock. It is not due to shock. So the hypotonia in the upper limb can be easily explained by the extensive radicular involvement from C2 to C5. So there is a definite element involvement at that level. Why is the lower limb hypotonic? For that, you have to see hypotonia with exaggerated reflex. That is what you are saying. The lower limb, the reflexes are 3+. So you have to see adductor hypotonia is there or not, you have to see. So exaggerated reflex and hypertonia happens in cerebral disease. Otherwise, you can get it in anterior console diseases. So that lower limb hypotonia or normotonia, I don't know. It is there's a lot of mismatch. The upper limb can be clearly explained by the radiculopathy. Lower limb 3+ reflex and hypotonia is difficult to explain. So you should look for subtle hypertonia by doing velocity dependent adductor abductor movement. Because in the lower limbs, it is the adductors which show the tone best, and in the upper limbs, it is the pronators which show the tone best. So when there is a difficult situation like this, you should look for adductor hypertonia in the lower limb and pronator hypertonia in the upper limb. Second situation where you can have hypertonia if the patient is on muscle relaxants, if he is on diazepam, if he is on baclofen, then the tone can appear apparently hypo, but then it should be symmetrical. You said that hypotonia is on the left side.
Yes.
So I will think that you should look for subtle evidence of adductor hypertonia. Repeatedly increase the velocity and do adduction abduction movement. You might find an adductor catch, I think so. And the tone hypotonia is subjective because upper limb you can do the shaking movement and posture, all those things. In the lower limb it is just your appreciation. Only situation where you get it is in the shock period, or the shock period reflex also will not be there. So it's very difficult to explain. So I would like to really confirm if it is very unlikely to be due to drugs, because drugs also produce symmetrical hypotonia, because it is asymmetrical hypotonia with hyperreflexia happens in antecondylar disease. So long segment antecondylar involvement is not possible in this situation. Drug is not possible. There is no radicular involvement according to you. So I'd like to look for adductor hypertonia. It may be either normal tone or adductor hypertonia, I'm expecting. So I would like to see that. So I think there is an asymmetrical cord lesion with a LMN involvement over a long segment from C2 to C5 with a asymmetrical myelopathy. So how are you going to explain this long segment radiculopathy? From C2 to C5 there is an LMN involvement. So how will you explain that? Most likely he had a severe injury and multiple root avulsion is one possibility. Second, traumatic subarachnoid, spinal subarachnoid hemorrhage with arachnoiditis. Severe trauma, you can have a traumatic subarachnoid hemorrhage with arachnoiditis. Second, you can have multiple root avulsion due to dynamic injury to the cervical cord. And asymmetrical cord involvement can be, because it is only posterior column. Posterior column did you look for?
Yes, ma'am. Posterior column is preserved, ma'am. Vibration and proprioception.
How many seconds is appreciating vibration?
Vibration 10 to 12 seconds in the upper limb, ma'am.
You have to look for timed vibration, you see, because it is very important. It is pressure sensitive to know whether this pressure or compression or non-compression. Because this root looks like avulsion, multiple roots. It looks like avulsion. Even if there is a demonstrable vertebral compression or a demonstrable disc there, an avulsed root does not recover. Supposing you have got only corticospinal tract on that side, then I would like to think of micro hemorrhages or cord concussion rather than compression. Cord compression means I am expecting posterior column and corticospinal tract. So if your posterior column is very well preserved in the angle, in a young person like this, you should appreciate 15 seconds timed vibration. In the anterior superior iliac spine, 20 to 25 seconds. In the upper limb, 20 seconds. If you are checked subtle posterior column like timed vibration, dynamic joint sense, and still you feel it is normal, then that corticospinal tract asymmetrical involvement is likely to be not due to compression. So multiple roots, either root avulsion with spinal subarachnoid hemorrhage producing arachnoiditis, and conduction of the cord producing corticospinal tract rather than compression, even if there is a vertical compression, vertebral compression in that line. What is the importance? A person with trauma can have vertebral fracture, but is that vertebral fracture the cause for his myelopathy? Is important to decide whether the surgery will help the patient to recover or not. So, so if it is true that C2 to C5 roots are involved on the left side, as you have presented, and he has got only corticospinal tract on that side and not posterior column at all, then I will think that he is having either multiple root avulsion due to dynamic injury to the cervical cord and contusion of the cord, or in the cervical cord, as I said, he might have had a cord contusion and a subarachnoid traumatic spinal subarachnoid hemorrhage. In which situation, even if you find a disc or even if you find a compression, that will not be the cause for the neurological deficit. It is important to prognosticate in a young person. So in this person, I feel it is either multiple root avulsion with cord condition or traumatic cervical subarachnoid hemorrhage with arachnoiditis and cord condition. That is my diagnosis. Cord compression, I will not be able to justify. You might find a fracture. That may not be the cause for this. Cannot explain. Now you show me the X-ray. Show me the X-ray.
X-ray image I didn't. I put a MRI picture.
Okay. What are the things you are finding in the MRI? Tell me. What is the atlantodental distance in this patient? It appears slightly increased. Normal adult atlantodental distance is, this is the odontoid, no?
Yes,
And this is C2 body, odontoid, then this is C1, and this is the anterior arch of the atlas. So you have to measure this in your scan. There will be a differential, this one I cannot measure. So to measure what is the normal distance in an adult, atlantodental. This is the dens, and this is the anterior arch of the atlas. This is the atlantodental distance. In a normal adult, how many millimeters? 3 millimeters. So it is 3 millimeters in an adult and 5 millimeters in a child. So it looks high, but I cannot measure in this. You have to measure in your image only.
okay.
Because there will be calibration for each machine. So it apparently looks that there is an increase in the atlantodental distance. Body of C2 appears all right. C3, C4, C5, C6, they are all looking normal to me. And cord is there. And in this part, I feel a hyperdense shadow in the upper part of the cervical cord. That could be a hemorrhagic condition. So apparently from this increase in the atlantodental distance and a hyperdense signal change in the lower part of the medulla to the upper part of the cervical cord, which could be a small condition. Then I'm not finding any fracture in this picture. Let me see the other pictures. Where did you find fracture?
Yes, C2.
There is atlantaxial dislocation that is there, but you have to measure the distance in your machine. And that will not again explain patient's neurological deficit. Okay. So he underwent the C2 decompression.
Yes, ma'am.
But can you explain his neurology by that? Definitely not. You see, C2 neuro, I saw that the atlantodental distance is increased, definitely. That indicates that there is a dislocation with fracture, without fracture. So here it looks like probably there is a fracture, but that is not. And he has a hyperintense shadow inside the cord here.
Yes, C2.
Yes, so I feel that the atlantaxial dislocation cannot produce a sensory loss from C2 to C5. It cannot produce. And of course, we can produce myelopathy below that. That can be asymmetrical or symmetrical depending on which part of the cord is more compressed. But it will generally involve the posterior column also. So the extensive radiculopathy, which cannot be explained by the atlantoaxial dislocation you are seeing, still means that it is not due to that. That is not the culprit. It is important for prognosticating. And there is a small speck of hyperintensity now that it is 1 month. I feel that he might have had a cord condition and he might have had a small hemorrhage inside the cord, and that would have produced extensive radiculopathy. That is made because it is of prognostic relevance. Because only the compressive component will improve with decompression. The non-compressive component, it is due to arachnoiditis. Slowly it might improve. It has nothing to do with the surgery. So that is what I feel. Is there any way in which you can explain that C2 to C5? If you have any explanation, you can tell me. I don't think there is any explanation.
Here.
It's not possible. Here one hyperintensity is there. Which one?
Nothing, ma'am.
Did you measure
Is
the
that-
atlantodental distance in this patient in your machine?
No, ma'am.
Yes, different machines will have different calibration. It definitely appears far away from the anterior arch. So there is a dislocation and there is a discontinuity in the pedicle. I agree on this side. But that decompression is not the cause for all the symptoms of this patient. That extensive radiculopathy cannot be explained by this at all. It is most likely he might have had a spinal subarachnoid hemorrhage at that time. That I am thinking all the more likely than one hyperintensity is there. And of course, there is a critical kinking of the cord at the craniovertebral junction. That is there. That can be due to the atlantaxial dislocation. But the extensive radiculopathy is not due to that. So fine, to conclude, there is a myeloradiculopathy again. And the radiculopathy is extensive. And this is not in the usual location of the common disc diseases or fracture or atlantaxial dislocation. So that extensive long segment radiculopathy has to be explained by either root avulsion or bleed. And I am not able to see the root avulsion in these pictures. Normally, root avulsion will appear like a thimble-shaped extension of the meninges along the roots. For that, you have to take focused cuts. Look at the root exit zone and look for the thimble of meninges. That I am not able to pick up in these pictures. So I am not sure whether there is an avulsion, but if you do the electrophysiological studies and look for the root latencies, you are likely to say whether the roots are avulsed. That is possible to say. So I feel it is either root avulsion, which I am not seeing here. These are not focused pictures for that. And or whether he had a arachnoiditis secondary to traumatic subarachnoid hemorrhage in the spinal cord. That is what I feel.
Ma'am, how to explain the cerebellar signs, ma'am?
You didn't tell any cerebellar signs, no? What cerebellar signs? Yes.
Finger nose test that was impaired on the right side. Can it be due to spinocerebellar tract involvement?
No. No, you see, he has a weak limb. You demonstrate to me the finger nose movement in this patient. You see, cerebellar sign, finger nose is a proximal one. The limb will move like this. Spinocerebellar tracts means it originates from the Clock's column. The Clock's column is not capable of producing finger nose incoordination. It will produce a subtle ataxia in a patient who is having spasticity and posterior column, typically seen in the spinocerebellar ataxias. And if finger nose incoordination never happens due to Clock's column degeneration. So this patient who is already having a weak limb, I want to see what is that finger nose incoordination. To say it is cerebellar, I want to see it. So cerebellar thing will be like this. It is not a distal clumsiness or slowly coming to the nose. It is a proximal movement. So proximally the whole limb will go around during finger nose test. That is cerebellar. So I didn't see that and I do not think that he has any cerebellar. What I do not think is there, no need to be explained. You see, in this patient, polytrauma, he can have cerebellar. If he has a cerebellar hematoma or a cerebellar injury, but none of those things are there. Neither cerebellar speech, no nystagmus, and cognition is perfectly all right, and nothing to do with the intracranial compartment. And that cerebellar finger nose you show me, then I will tell whether it is cerebellar. Clock's column will not produce finger nose incoordination. It will never produce finger nose incoordination. You show me the movement, those movements you have to show me, then we will mutually benefit.
Okay.
He has weakness now. The weak limb will be clumsy. That may not be cerebellar. Any other questions?
Can it still be in the hyperreflexia stage of recovery of spinal shock? Some literature says that spinal shock can occur like 12 weeks, 12 weeks, 3 months to 1 year.
I will have difficulty to call this spinal shock. He has definitely element sign. Why you want to pull the shock? No. I have not seen 3 months shock in any patient. And when there is asymmetry, we do not call it as a shock. Exceptions are not example. You might have read one exception where how did they prove that it is due to shock? Because if you say shock, you are going to tell the patient He is going to walk after some time. All his weakness is due to shock. It is not due to cord damage. So he is going to be all right. Will you be able to tell this person? I don't think it is shock. When there is asymmetry, extensive asymmetrical sensory motor involvement, I will never call it as a shock.
Okay.
It is not due to shock. Any other question you have? Any other question? Now, you see some rare case report where somebody thought it is shock. I think you should not be capitalizing on something which may be published without any conclusion or anything. Somebody might have thought some shock got prolonged and they may sometimes be lucky to publish. Those things you should not take. You should take only solid matters. Okay.
Okay.
You measure the translateral distance. That definitely appears more. That correction is good, but it is directly not related to the neurological deficit of this patient. So that correction is not the treatment which is going to cure this patient. So he has extensive root. You will have to see whether there is an avulsion of many roots. You have to concentrate on the root exit and the meningeal thimble there. But actually, I'm not very clearly seeing because it is all very half-assort there, and it is not focused on the root exit zone. So root exit zone, you will have to ask them to focus and take the look for the meninges. You can give a contrast and see. So if that thing is coming out, then it's an avulsion. Avulsed limb, you call it as a dud limb. Dud limb or useless limb. Usually they do not recover.
Okay.
How to?
You can do electrophysiology now. You can do the root potentials. You can do the F latency. That will give a clue. If you don't want to invest the patient for another imaging, you can do the F latency. What question you asked? Some question you asked, no?
Madam, how to examine for bilateral diaphragmatic palsy, in case you are thinking for him, because it's a delay of multiple roots clinically at LMN.
You look for the respiratory pattern and you can look for the diaphragm. You call it as Lytton sign. No? When you take the deep inspiration, you will see the diaphragm moving from its attachment. And normally, intercostals produce chest expand. Normally, if you have a intercostal paralysis, you find that if the diaphragm is paralyzed, you find that the epigastric angle becomes wide due to intercostals. If the intercostals are paralyzed, you find that the epigastric angle becomes narrow. So you look at the epigastric angle, look at the type of respiration. Is it abdominothoracic or thoraco-abdominal? If the diaphragm is paralyzed, normally the male respiration is abdominothoracic. It might become thoraco-abdominal. Second, if the diaphragm is paralyzed, the intercostals will pull the chest out. So there will be a widening of the epigastric angle. And if you are lucky, normally always you do not see, when the intercostal are paralyzed, only diaphragmatic movement will be seen as a Lytton's thing. And then you can do the radiological screening and look for diaphragmatic movement. You can even do electrophysiology. Phrenic nerve conduction can be done. Type of respiration. What about the epigastric angle? Are you seeing the diaphragmatic attachment getting pulled during deep inspiration? Those things you can check, and you can do a radiological screening of the dome of the diaphragm moving during breathing, and you can do phrenic nerve conduction. All can be done. Any other question? That's all.
No other question.
Because in this case, what you have to say, you found an atlantoaxial dislocation with a pedicle fracture of the C2, but that too has been corrected. That is very good, but that is not the cause for his neurology. That is a finding which might partially cause the myelopathy, but the extensive radiculopathy cannot be explained by that. So that part of it, the prognosis after surgery is guarded. Supposing you have got a disc prolapse, which is producing compression, the prognosis after surgery is good. Instead, as I said, if you have an Ellsberg, then prognosis after surgery is guarded. Ellsberg is infarct, it will not produce. Central cord, you find a patient with a central cord and a compression. You decompress patient, prognosis guarded. If you have a compression and that compression can explain all the neurological deficit of the patient, then only the decompression is going to give very good result. You have an incidental compression and most of the phenomena you are seeing in your patient cannot be explained by that compression, then your prognosis is guarded. You have corrected the compression, but that is not the answer for his treatment. That's the thing. You have to look at the roots and see, because even if there's a subarachnoid hemorrhage, it would have gone away. Now, you have to look for the root sleeves to know whether there is an avulsion and do the F. Then you prognosticate for the boy. That is the thing. Anything else? Any other question? No.
In this patient, ma'am, right lower limb anyway we couldn't examine properly because of the fracture.
Yes.
But lower like knee joint, ankle joint, power of right lower limb was like 3/5, lower
Yes.
compared to the right side.
Definitely.
So can it be similar to cruciate hemiparesis?
What cruciate hemiparesis?
Extrapyramidal decussation on the same side mass. Pyramidal tract decussation.
Why you are thinking cruciate hemiplegia for this patient? Cruciate hemiplegia is one upper limb and opposite lower limb, and the side of lower limb belongs to the pathology. No, and he has radiculopathy. No, this is not cruciate hemiplegia. This is definitely not cruciate hemiplegia. Cruciate hemiplegia is one upper limb, opposite lower limb, which is not radicular. Here it is clearly radicular upper limb on the left side. So this is not cruciate hemiplegia. Any other question? No. Shall we close then?
Yes, madam. No other questions. Any comments, final comments, suggestions for improvement, madam?
No, man. You see, trauma is a multi-axial injury always. So when we deal with a young patient like this, okay, you have done everything, but what is going to be the patient's future is a very big question. So will you be able to tell, I have corrected the C2 fracture, you are going to be all right. Is it all due to compression? That is your next job. So next job, clearly, everything cannot be explained by, he's a young man, he's only 23 years. So how he is going to plan his future? So you have to analyze the integrity of the roots, which cannot be explained by his C2 fracture, and decide what you are going to do for that. Is it a dead limb or is it a conduced limb? If it is due to spinal subarachnoid hemorrhage, a root integrity is still there, he can recover over a period of time. If it is an avulsed root, F latency is not there, he is not going to recover that limb. The lower limbs might recover because they are only partially involved. Maybe there is a multiple there is some hyperintensities, cord condition, cord edema may be there, so that might recover. So each part you have to find out which is going to recover, which is not going to recover. So that part of it is the next job. Whatever grossly you saw, I have many times we have seen cord, neurotomesis of the cord. That is completely the cord has been cut into two. And that person might have multiple vertebral fracture. Will you operate? Yes. Otherwise, the vertebra is also going to be unstable. But will he recover? No. I have seen neurotomesis of the cord where the cord is into two bits and you repair the vertebra. Okay, vertebral fracture is repaired. It has nothing to do with the weakness. That kind of situation. So here you have found a fracture, but that is not all in this patient. He is having. That is what you will have to pick up because physicians are not going to operate, but you will definitely prognosticate. So that part is the next phase of your job. How much will this patient benefit with the surgery from the neurological point of view? From the neurological point of view, you have to investigate the integrity of the roots. Cord might recover partly. Set the fracture, his right leg might improve. Then myelopathy is only partial in the lower limb. It may be due to, there is definitely hyperintensity, so it's a cord condition. Over a period of time, he can have little more recovery of the limbs. But what about the left upper limb? That, as I told you, have to investigate and then tell whether it is an avulsion, it will not recover. If it is spinal subarachnoid hemorrhage, F latency can be there, and then patient can have some more recovery. That is the prognostication. Anything else? Shall we stop?
Yes, ma'am.
Yes. Thank you.
Thank you so much, ma'am.
Thank you.